Welcome to the virtual presentation of Paw and Order. My name's John Crumley. I'm an investigator with the Nevada Veterinary Medical Board. Thank you for joining me. Okay, let's get on to the legal stuff first. I'm not an attorney. I'm not here to give you legal advice. My goal is to give you the tools to develop your best practices using hypothetical examples. I'm not here to give you legal advice, and I'm certainly not here to tell you what to do with your practice. My goal is to lift the veil from the complaint process. I want to talk about the role each board staff member plays in an investigation, and then I want to describe how the board evaluates a case to come to their decision. And then I want to discuss some common questions with some case examples. The presentation is divided into 4 sections. The first 3 talk about the process in general. So we'll start with the investigation. Who can generate a complaint? Why would someone file a complaint? And then we'll talk about the most common complaints filed with our office. And we'll talk about the steps of the investigation from start to finish. We'll move on to case review. How does the board, through the investigation committee, decide a case? And then once the case is decided, what are the possible outcomes? And then we'll discuss the most common violations that we see. And then we'll get into the 4th part of the presentation, go over some common questions with some case examples. So let's start at the beginning. Who can file a complaint? The vast majority of our cases are filed by our clients. But the veterinary medical board may file a case, as well as another veterinary professional. This may be a colleague or a coworker. If it is a colleague or coworker, they may choose to file anonymously, or they may file a formal complaint. Also, other boards and other agencies can file complaints. The Nevada Pharmacy Board is a good example. Another state veterinary medical board is a good example, as well as the DEA and the USDA can file cases with our office. The vast majority of our cases, though, are filed by clients. In the remainder of this presentation, we're going to describe the process as if a client files the complaint. So why do clients file complaints? Certainly something like an anesthetic death is nothing anybody expects when they bring their pet to a hospital. However, we all know that it does occur. So undesired outcomes are a very common sources of complaints. Complications from procedures do occur. Obviously, a good example for that would be an iatrogenic infection from a surgery. Oftentimes, these complications form the genesis of a complaint. But sometimes a complication doesn't occur, a mistake is not made, but the client loses faith in the veterinarian and they turn to our office and file a case. Sometimes when a client loses faith in their veterinarian or has an undesired outcome, they reach out to their veterinarian and they may not get the answer that they want, or they may not get an answer at all. If they don't get the answer that they want or a satisfactory answer, they file a case with our office to try to get answers to their questions. So the investigation starts with identifying the subject. Who can be the subject of a veterinary board case? 3 main categories: veterinarians, licensed veterinary technicians, and the hospitals. So the first thing we do is identify who is the licensee that is the subject of the complaint. Is it a veterinarian, a licensed veterinary technician, or is it the hospital as a whole? The next step is to identify what we call secondary facilities. These are hospitals, veterinarians, and technicians that have cared for the patient, but are not the subject of the investigation. The reason we identify these secondary facilities is we request medical records. So we'll send either an email or a phone call or something in the USPS to request the medical records to help with the investigation. And the next step is to notify the subjects of the complaint. That's done through an email and a certified mail letter. In that letter, there'll be instructions on how to respond to the complaint, as well as the complaint itself. Namely, the response to the complaint is a written response to the complaint that addresses the concerns arise in the complaint letter, and then also the medical records, including diagnostic imagings, such as radiographs or ultrasound. After all the material has been received, so we've sent out the notice, we've received medical records from the subjects of the complaint as well as the secondary, and then we received the response from the complaint, then the case is assigned an investigator in the investigation committee. What's the role of the investigator? What do I do when I'm assigned a case? The first thing I do is I review all of the material that our office has received. I go through the complaint, the response to the complaint, all the medical records, and I redact all of the names. The reason I do that is because I'm going to submit that to the board for their deliberation. And we want the board to base their decision on the facts of the case, not on prior knowledge of the individuals. After I've received everything and redacted all of the names involved in the case, then I proceed on to interviews. I start by interviewing the complainant, and then I proceed to the subjects of the complaint, and then any staff members that I think may help in my investigation. And then I document everything. I take notes during my interviews, but I also take notes as I'm reviewing the documentation, the complaint, the medical records, the response to the complaint. I write all of that into a summary document and then present that to the committee. So who are the investigation committee? The investigation committee is made of a subset of our board. Who's our board? Our board is made up of 6 veterinarians, 1 licensed veterinary technician, and 1 member of the lay public, all are volunteers and all assigned by the governor. The committee meets once a month to deliberate cases. Prior to that meeting, they've received all of the documentation 1 week prior to evaluate. So when they meet, they discuss the merits of the case and deliberate what the decision is. After the committee makes a decision on a case, the subjects and the complainant are notified via email. So how do the committees deliberate a case? What do they refer to? Well, the first thing they refer to are existing regulations. NRS 638 and NAC 638 are our statutes and regulations regarding the standards of care. As you may guess, though, not everything in medicine is written into the statutes and regulations. One of the most common examples, I would say, are medical record requirements. How long do you need to maintain a medical record and what needs to be included? Where can you find them? Our website has links to them, and certainly you can look at the state legislature's site to find them. But I would say the easiest way to find them is from our website. The second thing that committees refer to is the 2003 AVMA Code of Ethics, which have been adopted by our state. But most commonly, what the committees are deliberating and comparing the actions of the subject of a complaint to is what we call the standard of care. So let's define the standard of care. I can tell you what the standard of care is not. It is not the ideal care. It's not the gold standard of care. The way I think about it, it's a reasonable veterinarian on an average day. Not me on Monday morning after a great night's sleep and 2 cups of coffee. It's more like me on Wednesday when I'm tired. It's a reasonable veterinarian on an average day. General practitioners have a different standard of care than specialists. General practitioners are held to the standard of care of their fellow general practitioners. Specialists are held to the standard of care of their fellow specialists in their field. Fortunately, the standard of care evolves with medicine because medicine moves much faster than government. We wouldn't want the pace of the standard of care of medicine to evolve at the pace of government. So it must evolve with the pace of medical care. So ultimately, the standard of care is determined by the board, and it's unique to each case. What are the outcomes of the committee meetings? The committee may vote to either dismiss or proceed with discipline. If the committee votes for dismissal, no further action is taken. The record is kept confidential and all parties are notified, typically via email. The committee may vote for discipline. If the committee votes for discipline, a letter of correction or letter of reprimand is sent to the licensee for their approval. And if approved, that letter will go before the entire board during the public meeting for its final approval. I've included some statistics below. From 2020 to 2024, our office received roughly 300 cases. Of those 300 cases, roughly a quarter of them resulted in discipline and 3/4 resulted in dismissal. From the time that we received a case to the time the case was closed was roughly about 4.5 months. What happens when a committee decides for discipline? What are the options as a licensee if you receive a letter of reprimand? Well, the first option is to not accept it. You may say, I don't agree with the committee's findings. I want a hearing, and that is allowed. A hearing would be arranged, and the licensee, plus or minus their attorney, will be allowed to present their case, and a final decision will be made. but that's very rare. The vast majority of our cases do not proceed to hearing. Most licensees accept the letter of reprimand. If so, the matter is considered settled. The letter is made public during the public board meeting and on the board's website, and then the board monitors for compliance with the conditions of the settlement. Again, the vast majority of our cases are settled. So let's talk about common violations. Dishonesty. Unfortunately, it is something we see. I always say, don't lie to your clients, don't lie in your medical record, and never lie to the board. Inadequate medical records. As you would guess, this is a very common component of complaints, but it's rarely the sole source of a discipline. If it does result in discipline, it's oftentimes associated with another violation. Inadequate informed consent. I think informed consent deserves its own slide. So let's talk about informed consent. This is the definition by NAC 638, but I don't want to belabor you by reading it. You certainly can read it yourself. But what I would like to highlight is a few things. Informed consent is our job as the professional. Our job is to communicate the information that we have so that the client can make a decision for their pet. And a few things are key components are oftentimes overlooked. Reasonable person. We must talk to our clients in a manner that is understandable. We must discuss the options of recommendations as well as the risks of the recommendations that we provide regarding their pet and the prognosis. And then finally, an estimate of fees. These are key components of informed consent that oftentimes are overlooked and result in discipline. So going through our common violations again, we've got dishonesty, inadequate medical records. Again, that's oftentimes an additional discipline on top of existing disciplines. Rarely medical records are the sole source of the discipline. Inadequate informed consent. And then what we're all familiar with, medical or surgical incompetence and negligence. So what do those terms mean? What does incompetence versus negligence versus malpractice? What's the definition of these terms? They are defined by NAC 638.045. You can look it up and read the legal definition. But the way I think of it is incompetence is you made a mistake, but you didn't know any better. Negligence is you made a mistake, you should have known better. And malpractice is you should have known better, you made a mistake, and it resulted in the harm to an animal. Primarily what our board deals with are incompetence and negligence. So again, incompetence defined as a lack of knowledge or skill. I think of it as you made a mistake, you didn't know any better. Negligence is a departure from the standard of care. I think of it as you made a mistake even though you knew better. Okay, let's move on to the questions and case example section. If you're viewing this online, the following is a pre-recorded virtual presentation. You will not be able to ask questions during the pre-recorded session, of course, but at the end of the session, it has my contact information. If you have any questions, please feel free to reach out to me. Okay, that's the boring part, at least the boring part to me, because I can't stand listening to myself talk. This is a time where I want to open up to questions, and then we can get into some case examples that hopefully will bring some questions as we go along. Because the case examples that I've created kind of they try to highlight an aspect of common complaints that we see. It's now about 8:25. I do have a hard stop at 10 o'clock. So I will have to get off the call at 10 o'clock for a meeting. But if you have a question that I haven't answered, my email appears at the end of this talk. Feel free to email it to me. Same thing, if you have a question that you don't want to be recorded, just email it to me, no problem. Does anyone have a question about the process in general so far? I have some questions then. What are the outcomes of cases? What are the two possible outcomes? Anybody just unmute and chime in.
Dismissal, or I guess reprimand is I don't remember what word you used. But
discipline, reprimand, all those are fine. Yeah, they're fine. They're synonymous. Yeah. And which is more common from the last 4 years that I've done the numbers?
dismissal.
Yeah. Yeah. Who determines the outcome of a case?
The committee?
Yeah, the committee, and then final approval by the board, right? So the committee can dismiss a case or proceed with discipline. If they vote to proceed with discipline, it goes before the entire board for their approval. Then if approved, then it's made public. Good. When's the time to call an attorney? When would you call an attorney? And this isn't based on the presentation because I didn't talk about it. I'm just curious about you guys.
Probably if I was disciplined and I wasn't going to settle.
Yeah, so after you've received that letter of reprimand and you're like, I don't accept this, I want to go to hearing. Absolutely. You would not want it. You can go to a hearing without an attorney. I would not recommend it because the board's attorney is going to be on the other side of that table. And the board's attorney is very good. Anybody else have a thought of when they'd call their attorney?
Allie said right when you get that letter.
You know, I think there's no wrong answer here. You know, Dr. Quilling's response of like, hey, only if I want to go to hearing, Dr. Schrader, maybe when I get the letter, and your guys, right when I get the letter. I think those are good answers. You know, one of the key things is the investigation does not proceed any differently if attorney's present or not. It doesn't affect my investigation. I go through the same process with or without an attorney. So I always tell people, if, for example, they don't have an attorney, I say, well, you can get one while we're having this conversation. If at any point you decide, you know, I don't want to answer that, I'm going to talk to an attorney, I don't hold it against you. You know, go ahead, you know, get an attorney, that's great. And then we'll have them on the call and we'll talk together. I have conversations with veterinarians without their attorney. I have conversations with veterinarians and technicians with their attorney. To me, it makes no difference. I do like the one argument that I've heard from professional liability insurance trust or PLIT. It was like, you pay for this, why don't you call us for advice? And that's some sound logic. I must admit, of the 4 cases I've had against my license, I didn't have an attorney, which is kind of funny in the role I am now. But anyway, all righty. Any questions about the process before we move on? Okay, well, let's get into some case examples. So these cases that I've put together, I'm not presenting a case that was disciplined by the board or that was reviewed by the board and dismissed. I'm not presenting an actual case and just taking the names out. What I've done is I've taken amalgamations of multiple cases. So each case that you see presented, those cases are a combination of a minimum of 2, if not 4 or 5 cases. So the reason I do this is I would never put a case of a licensee in a presentation like that. That would be completely inappropriate. I wouldn't do that to you guys, and I wouldn't want anybody to do it to me. But if you're seeing one of these cases and think to yourself, well, that sounds kind of like a case that I went through. Well, it means you're not alone. Somebody else went through it as well. At least 1 or 2 other people went through it as well. So let's get into case 1. So we've got Pumpkin. Pumpkin's a 12-year-old neutered male Yorkshire Terrier. Owner dropped Pumpkin off with Dr. Brumley for a dental. Owner met with Dr. Brumley after the dental, and Dr. Brumley said, hey, everything went great. Pumpkin's doing wonderful. You take him home. So owner takes Pumpkin home, and Pumpkin won't eat for 2 days. And so they think, this isn't right. I'm going back to Dr. Brumley. So they bring Pumpkin back to Dr. Brumley, and unfortunately, Pumpkin was diagnosed with kidney failure and was euthanized due to the poor prognosis. The owner filed a complaint with this board saying, hey, the anesthesia or the dental, something caused this kidney failure because Pumpkin was completely normal before the procedure and then had kidney failure after. And that's oftentimes a perception that we see of clients with complaints, even if the pet wasn't completely normal prior to the procedure. So the notification goes out. Dr. Brumley provides medical records as well as a response to that complaint. And during the review of the record, the investigator noted, hey, there was some azotemia. I think the BUN was 55, creatinine was above 3 on the pre-anesthesia serum chemistry. No intravenous fluids were provided during the 20-minute dental procedure. And there's no notation of the client communication as the results of that pre-operative serum chemistry. When Dr. Brumley was interviewed by the investigator, they said, well, yeah, I saw the azotemia ahead of time, but I didn't think it was bad enough to warrant calling that client, worrying him about it. And I just proceeded on with the dentistry because I know that's what Pumpkin needed. And we don't typically give intravenous fluids for such short dental procedures. I see some shaking of heads. I see a couple nods. Somebody give me your thought. If you were on the board, what are any red flags you're seeing?
One red flag is the fact that he didn't address the azotemia in the beginning, because that is also something with anesthesia we want to make sure that we are taking care of, and making sure the owner is aware that we're about to anesthetize them, or even just doing sedation for a procedure that can cause problems. So the fact that he didn't say anything is concerning.
Absolutely.
And it wasn't transparent to the owner.
Absolutely. Anybody else have another red flag?
I'm not an internist. Well, hey, there is an internist, but I don't know that I'd say a CREAT of 3.3 is not severe. So it could be worse. It could be worse, but I don't know that that's,
I think too, like not modifying your claim based off the results.
Ashley, there's some feedback. I'm having a hard time hearing you on the mic.
Is it better now?
That's better. I'm going to mute Dr. Schrader. I think it might be coming from her mic. Yeah, it is. Dr. Schrader was your mic. Go ahead, Ashley.
I was just saying, not modifying your anesthetic protocol based off of kind of their pre-op blood work. Like you've got new information. Yeah, you don't maybe typically do that for a short procedure, although I feel like that's debatable on whatever. But then you have this and you didn't not only not call the owner, but then also just not modify your plan to adjust for it is, I think, a big flag.
That's a really good point. Not changing your plan and changing your conversation with the owner when you've received new information. There's an important phrase regarding something we've talked about in this presentation, a legal term, a legal phrase that'll come up. Unless anybody knows what it is, please pipe in. And then Dr. Schrader, if you want to try to unmute, I know you wanted to say something, but it had some feedback. I don't know if you want to try to unmute again, see if we can hear you.
No, I'm good. They said all the things I thought. So.
And that's much better too. Yeah, that sounded good. All right. Well, let's go on. Let's see. What did the investigation committee determine? So the committee voted to discipline Dr. Brumley for failing to reestablish that phrase, informed consent. So Dr. Brumley got new information, azotemia, and didn't reestablish informed consent based upon that new information. And also for falling below the standard of care of providing supportive IV fluids during anesthesia in a patient with anesthesia, patient receiving anesthesia. So what happened? Dr. Brumley receives a letter of reprimand. Dr. Brumley agreed to the letter of reprimand, including paying fees and costs, the investigation fee and attorney fees of $650 is pretty typical of a case like this. And Dr. Brumley agreed to attend 2 hours for continuing education on informed consent and 4 hours of continuing education of kidney disease. So you can see that discipline is recovering costs from the board. And then second is intending to provide information. It appeared in this case that Dr. Brumley didn't know better. And so the goal of the board was, we don't want this to happen again. So let's require some education. So this education, so this is what, 6 hours? So do you think that this 6 hours should count towards Dr. Brumley's license renewal? Because we need, 40 hours every 2 years? See a lot of head shakes no, and that is correct. Typical discipline from the board, if we require discipline, those hours are not counted towards renewal. So Dr. Brumley would have to perform 46 hours of CE to get the license renewed. Dr. Quillen, you had a question?
Does the board choose which continuing education you're attending? Like if you say it has to be on kidney disease, then do you present options for people, or is it kind of up to the person to find those? Not all continuing education is equal, but.
Yeah, That's well, it has to be approved by the board, right? So we're not going to let you, go into a magazine and fill stuff out and then send it in and you're good to go. No, it has to be approved by the board, but it is up to the licensee to find the education on the category that the board has determined. But the board has worked with veterinarians. Like if the veterinarian says, look, I can't find 4 hours on kidney failure education, we will help them out. And we often have in the past, but ultimately it's up to them and it's up to the board to approve it. But you're right, not all continuing education are equal. Anybody have other questions or comments on this case? Want to move on to the next one? All right, so let's talk about case 2. So we got Billy Boy. Billy Boy is a 1-year-old neutered male Labrador. He presented with a 4-day history of vomiting to Dr. Kermley, and this was 5 minutes before closing on a Friday. I see the emergency technicians laughing. This never happens, right? Never happens in an emergency hospital, never happens in a day clinic. Yeah, never. Yeah, always happens. And the owner said Dr. Kermley just recommended, let's try some medications for the nausea and let's just see how it goes, right? So they gave it an injection of Serenia. Billy Boy was sent home with instructions, keep an eye on him for vomiting. If you know how quick readers you are, those of you that are at ER, what do you think happened? What happened with Billy Boy?
He ate something.
So what happened when he went home? Yeah, so he goes home for the weekend. What did he do?
He vomited through the Serenia.
Yeah, vomited through the Serenia, or in this case, I put in there that he vomited well for that first 24 hours while the Serenia had the blood levels, and then he started puking again. And now what is it? Saturday, right? So he has to go to the emergency hospital on the weekend, have the foreign body removed because you guys called the diagnosis right off the bat, and client wasn't happy with that. So the complaint was filed with our office saying that, hey, Dr. Kermley missed the obstruction and made us go to the emergency clinic and pay double the fee. So the notification of the complaint goes out. Dr. Kermley provides medical records and the written response. The emergency hospital sends their medical records. An investigation committee is assigned. The investigator goes through the medical record and interviews Dr. Kermley. So Dr. Kermley says to the investigator, hey, I recommended x-rays, blood work, but the owner said, I'm not going to do it because of expense. So what does the investigator do? Goes to their medical record, and the investigator sees in the record that there is a notation that Dr. Kermley had recommended diagnostics. He did recommend radiographs, and the owner declined. But on further review of the medical record, the investigator was able to determine that Dr. Kermley modified that medical record and did not properly amend the medical record. So when they modified it, they didn't properly amend, showing the date of when they made that change. And in the initial notation, the investigator was able to determine that on the day of the exam, Dr. Kermley just recommended empirical treatment, did not recommend diagnostics, but on the revision, which was not properly amended, Dr. Kermley recommended radiographs and blood testing. So this talks about amending a medical record. Who's familiar with amending medical records? All right, most of you guys are. Dr. Quillians, your hand was up first. What do you think is the proper way of amending a medical record?
I guess I'm lucky that our computer system, basically as soon as I finish, I click final. And then if I want to make any change outside of that, the only option is for me to make an addendum, and it is date and time stamped at that point. So it's really easy for me to know exactly when I did these things because that's just how our system is set up. But I always tell my technician, if you're having a client communication and you know you can't type it in immediately, you have to type it in 3 hours later or whatever, always put I typed this in later. It actually happened at this time. So again, I would rather finalize my records too early and add an addendum at the appropriate time, on the right day, than go back and go, oh no, it never got finalized, and then it becomes a lot harder to track. So at least for me, our record system is easy that way.
Sounds like you use Cornerstone, is that right?
Yeah, we use Cornerstone.
Yeah. So you hit the nail on the head. When you make an addendum to a medical record, we're allowed to go back into our record and adjust it because we may need to correct something. Like, oh, I wrote I gave 2 mils when I only gave 1 mil. We're allowed to do that, even if it's weeks, months down the road. But we must, especially if it's weeks or months down the road, we must make that addendum time and date stamped, like Dr. Quilling said. There are some softwares that handle this differently. So a good example would be a contrast between Infinity Impromed and Cornerstone. So Infinity Impromed, when you make an adjustment to a medical record, the software on Infinity Impromed adjusts and time date stamps automatically. So if you go into, let's say you see the patient on Monday and you didn't put in your physical exam, you forgot. Now it's Wednesday. You go back and put in your physical exam notes on Wednesday for Monday. Infinity Impromed will note that you made this change on this day, this time, and it can be seen by what they call the revision history. Cornerstone operates differently. Cornerstone, when you create a note or an entry, it starts out as tentative. That tentative record can be adjusted at any time, and there is no tracking of those adjustments in a tentative. So once it's finalized, then you are not able to adjust it, and you must make a time date stamped addendum. So what I typically recommend people with Cornerstone is there is an automatic setting where you can auto finalize your records. I typically say 48 hours is a reasonable amount of time, and you can make adjustments on or about the exam. 48 hours is a reasonable amount of time. Then it's finalized, then all addendums need to be time and date stamped. Because again, we're human. We make mistakes in our documentation. We are allowed to correct those, and we make omissions in our medical records, and we're allowed to fill those. But we got to make sure we do them honestly. So in this case, Dr. Permley, does anybody think Dr. Permley did it right? No, of course not. Yeah, you can't go back in and modify your medical records to say something that didn't happen. Secondarily, the emergency hospital didn't receive a copy of Dr. Kermley's records. So those of you that work in specialty hospital or emergency hospitals, has that ever happened? You ask for medical records? Yeah, everyone's laughing. Yes, it happens all too often. Does anybody know what the regulation is from when a client or a board or an agent of the client or board asks for medical record? How long does the licensee have to submit that medical record?
48 hours.
Yeah, 48 hours. That's the old regulation. So it used to be 48 hours. We have changed that regulation to 5 business days, with the exemption of, in case of emergency, the licensee is allowed to submit incomplete medical records so that the care of the patient isn't impeded, but it also gives them time to complete and finalize their medical records so it is complete. So the old one was 48 hours, no business day, just you got to do it. And what a lot of day practitioners experience is they close on Friday. Now it's Monday, they're in violation. So we have adjusted the regulation to 5 business days while allowing the practitioner to send incomplete records. So my general recommendation for a practitioner, if it's Friday and you're seeing a patient and you did x-rays and blood work on this patient, give them that. Give that to the client so that they have that, and at least if they go to the emergency hospital, they don't have to repeat it. That's what was very frustrating for me as an emergency practitioner. Hey, I got to run some blood work. Well, they ran it Friday afternoon and it's Friday night. Well, I can't get that information. Clients oftentimes think we have the ability to go into the medical records of another hospital and get those results. We all know we don't. We have to repeat the test. So 5 business days, you're allowed to set incomplete records. That does bring up a subject that is near and dear to my heart, is when the board makes changes in regs, it can be years until it's codified by the legislature and then is easily accessible via Google search. So if I want to see what the code for medical records is and I type in NAC 638.045, it'll come up the old reg and it's going to say 48 hours. But I just told you it's actually 5 days and you can send in complete records. Where do you find that change? Well, if you're a government nerd, you can go into LCB, and if you know the specific bill number, you can go search for that bill and then find it. It takes way too long. Our executive director has actually gone through the new changes and updated our website. So if you go to our website, there's a section on the left side that says what's new. Click on that what's new section, and it'll talk to you. It'll outline all the changes that are made, and it'll link you to those changes that you can see them. They're even outlined by topic. So there's things like new things that veterinary assistants are permitted to do under certain supervision. Same thing with LVTs. There's a lot of new things that have happened actually since this last February that are in there for you. So I encourage you to go into that section of our website, look at the what's new, because we are held to that standard. That we are held to the changes. All right, so what happened to Dr. Carmely? You think he deserved discipline? Yes. I mean, this is dishonesty. This breaks my first common violation, third rule: don't ever lie to the board. They lied in their medical record, and then they lied to the board. So the committee voted to discipline Dr. Carmely for inappropriately modifying the medical records, and also for failing to transfer the medical records to the emergency hospital. Because in this case, the emergency hospital still hadn't received the medical record weeks after the fact, let's say. So the letter of reprimand was presented to Dr. Carmely. Actually, let's go back. Other than fees and costs, if you were on the board, what discipline do you think is fair for this case? Let's say Dr. Carmely had no prior disciplines. This is the first. Nobody wants to throw the hammer down. Think about it this way. The goal is for this not to happen again, right? So continue education hours on ethics, of course. Continue education on medical records, of course. How about submit a revised hospital policy that talks about medical record transfer and how Dr. Carmely handles medical records? And then how about some supervision? How about the board spot checking those medical records? Dr. Carmely's got to be in compliance, and so he's got to submit themselves to unannounced inspections of medical records randomly. So that way the board can determine that they have come into compliance. Any thoughts on that? Does that seem fair, or anybody think we're being too hard or too soft?
I think it's fair, specifically having his medical records being inspected for a certain period of time to make sure he's keeping up with the compliance and passing information around. But my question is, so we know they went to the for vomiting, and the doctor decided to outpatient care. And then we know that they go to the ER because we missed it. Most of the time when we got them for ER, they tell us that information, and it's usually on a Saturday. We can't get information afterwards, but we just treat it for what it is. And then we don't ask for records, or if we do, we kind of let it go. And then we're like, okay, we know what we have now. We've already did surgery. Would that still be under, they have to send us those records? Because I've never gotten the situation where we still ask for records even after we get the patient. Because I was working in the ICU, so it's like I would look through the records and look through if I needed more information, or would the records still need to be sent regardless?
That's a good question. Records do not automatically need to be sent to another hospital. It has to be on the request of the owner or an agent of the owner. So if you're at the hospital requesting records on behalf of the owner, you're acting as an agent of the owner, or from the board or an agent of the board. So the requirement is you must supply your medical records within 5 business days of the request of the owner or the board or an agent thereof. But you're not required to send them just because the pet went to another hospital. Is it best practice? Sure, you should. I mean, that way we always want to make sure that the patient has continuous medical care, but it's not required. It's a good question. So
Yeah, coming from California, you have so many hospitals that you're like, well, we did this, and then we see you at the big hospital, and the things we have to share with each other in different ERs that we're like, okay, we need to talk to each other. And so that's why it isn't necessary to get those medical records when we're already treating it for what we already know. And the owner told us we already went to the PDVM. Usually we ask for them, but on a Saturday, they're usually not open, or they're there
Yeah.
at 2 in the morning. And we're like, well, we can't get them.
Yeah, and if they're not asked for, then it's not a violation for failing to provide them. But if they are asked for, you got to provide them. Yeah. That brought up another question in my mind about medical records, and I just lost it. Try to think. So it'll come to me. Let's jump on to the next case. It'll come to me. All right, case 3. So Precious is an 8-year-old female, say, Bichon Frise. If anybody's a Silence of the Lamb fan, you probably can't get that voice out of your head, because I know I can't. All right, presented to Dr. Crowley as an emergency with an acute onset vomiting after eating a rubber toy. Radiographs showed, looks like there's an intestinal foreign body. Dr. Crowley goes in there and takes out that foreign body and sends Precious home with the owner. 3 days later, Precious gets a skin infection right on the incision. Goes in as at the regular veterinarian now and says, hey, this must have happened from the surgery. So the owner files a complaint with our board against Dr. Crowley, says that they must have done something wrong during the surgery that caused this infection. So the notification goes out to Dr. Crowley, includes a copy of the complaint. Dr. Crowley provides a written response in the medical records, including those radiographs, and a notification goes out to the secondary hospital, and they provide medical records about the skin infection. Investigators assigned, and they start digging through stuff. So what does the investigator find? So they look at the radiographs and say, yep, looks like there's a foreign body with some gas distension of the intestines. They looked at the anesthesia report and shows vital signs were recorded every 5 minutes, and there didn't seem to be any complication during the procedure. Why does anybody think I put vital signs were recorded every 5 minutes? Does anybody know the reg?
While any patient's under anesthesia, you have to be recording their vitals every 5 minutes to make sure that we're keeping proper care.
Yep. Exactly. You must record, the anesthetic drugs, the pre-anesthesia exam, including TPR and thoracic auscultation, within 12 hours of general anesthesia. During the general anesthesia, of course, you must record all the drugs that have been given, and you must record vital signs, not limited to, but including TPR. And then you must have some notes on patient recovery, and that the patient was standing at the time of release to the owner, unless they are being transferred immediately to emergency hospital. So good. All right, so they didn't see any complications with the vital sign recording. So they looked at the surgery report, and they see that Dr. Crowley removed the foreign body from the large intestine via colotomy. And they look at the post-obstruction radiographs post-operative observations and saw that the vital signs were normal, and that Precious was walking at the time of release. Anybody have any concerns here before I tell you the answer? Dr. Schrader's come in.
I have concerns. Why did they remove a foreign body out of the large intestine?
Yes. It's called the large intestine, not because it's longer than the small intestine, because it's wider, right? I always would tell clients, if they can get through the small bowel, it's going to get through the large bowel. So why do we think Dr. Crowley may have removed the foreign body from the large intestine?
When you looked at the rads, it was in the small intestine, and you're going through and milking everything and trying to make sure you don't miss it, and you don't realize you're in large intestine now, and so you cut into it, which we all know kind of increases your risk of infection and stuff. But when you looked at the rads, you were going in with the mindset of, I'm going into the small intestine.
That would be the definition of negligence, right? Dr. Crowley knew better, knew not to cut the large intestine, but got confused during the procedure and made a mistake. Or made the mistake on the assumption that on the radiograph it looked like it was in the small bowel, and then found at surgery it was in the large bowel and got confused. Yeah, that's a good reason. Anybody else have a thought? What about incompetence?
They're about to charge a client for a abdominal explorer, better come back with something.
Yeah, so fraud, deceit, say, look, I'm in here, I better come back with something. I'm just going to do something that I know was wrong so that I can justify the procedure. Yeah, that would be fraud. That would be dishonesty. Okay, well, let's move on. Let's see in this case. So Dr. Crowley told the investigator this was the first time they ever saw a colonic foreign body. So the committee voted to discipline Dr. Crowley for departing from the standard of care of surgery. We all know, don't cut the colon. If it makes it to the small bowel, you can move it out. Letter of reprimand was presented to Dr. Crowley, and it was based upon incompetence, because Dr. Crowley said when he was talking with the investigator, this is my first time I ever saw a colonic foreign body. You're telling me I'm not supposed to take it out of the colon? I didn't know that. So this is the definition of incompetence in this case. And remember, as I said originally with these cases, this is not based on one case. This one actually is based on about 5 or 6. So Dr. Crowley agreed to pay fees and costs, $825 in this case, and agreed to attend 4 hours of continuing education on radiographic interpretation for GI disease. And the reason in this case was because the investigator in this case determined that on the radiographs, the foreign body was clearly in the colon. It was not in the small bowel. But let's say you're in practice and you have a question about if the foreign body is in the colon or not. What's a diagnostic test you can perform to determine if that foreign body is in the colon or in the small bowel? Alicia?
I was going to say, can't we just send them off to a radiologist to make sure that we are aware of where we're at? Because we can read it and we're like, it looks like it's here, but then we send it off to the radiologist and them confirm it is there, and then we can wait to either decide to cut it or to let it see how it's going to progress with fluids. And that way we can inform the owner. It's like, hey, we think it's in the colon or it's getting close to the colon, so let's put him on fluids, let's monitor him overnight, and let's see how it goes.
Excellent. Yeah, send it off for radiology review. That's a great option. Anybody have another option?
Would a barium study be something that could happen?
You could do an upper GI to see if you could identify a small intestinal foreign body. Also, barium is what I was taught in school, barium push. Sometimes barium studies can be therapeutic for partial foreign bodies, can help move things along. So barium study is a good option. Ultrasound, great option.
Pneumocologram.
Oh, my favorite. That is the gold star of the day, pneumocologram, the most underutilized radiographic diagnostic interventional procedure, in my opinion. Blow some smoke up his butt and see if you can outline the foreign body. Yes, pneumocologram, gold star. All right, I'll get off my pneumocologram. What do you call it? Pneumocologram soapbox. All right, so in this case, Dr. Crowley also agreed to attend 4 hours of education on surgical management of GI disease. Because again, the board determined in this case, this was incompetence. This wasn't deceit. This wasn't negligence. Dr. Crowley just didn't know. He lacked the knowledge, skills, or ability. So the goal is let's educate. Let's make sure that Dr. Crowley educates themselves. Hopefully learn just from this case alone, but also may learn some other things from the continuing education. Going to be okay if I move on to Morky the Yorkie? Okay. Morky is a 6-year-old neutered male Yorkie. He is presented to Happy Pet Animal Hospital for anesthesia and dental treatment. Mr. Canal, a licensed veterinary technician, assists Dr. Brumley with the anesthesia and dental evaluation. Dr. Brumley, in case you're wondering, yes, these are all mispronunciations of my name I've actually heard during cases just for fun. So Dr. Brumley found a complicated crown fracture of one of the teeth, 304. Dr. Brumley says to Mr. Canal, hey, I'm going to deal with the rest of this dentistry. Why don't you go call the client, talk to them about either extraction of this tooth or root canal. We'll refer to root canal if we need to. Otherwise, we can extract here. So Mr. Canal's like, I know this client. They can't afford root canal therapy. So when Mr. Canal talks to the client, he says, look, you just got to take this tooth out. Mr. Canal didn't discuss root canal therapy because he knew they couldn't afford it. So he says, let's just take this tooth out. And the client agrees. So Dr. Brumley extracts the tooth, and Morky the Yorkie recovers well and goes home with medications, pain medicine, antibiotics. So, you know this tooth, extracted the tooth. Can you foresee any possible complications here? What the client might not be happy about? It's 304. Ashley, you're laughing, or is it something else?
Oh, the tongue's going to be hanging out the mouth.
You got it. Yeah, we've all seen those dogs. I actually think they're kind of cute, unless the tongue gets all dry. But the client was upset. The tongue kept protruding. And so what do? They go to a dentist. We're going to say, what can be done about this? Can we do doggy dentures? What can we do? So they go to a veterinary dentist, and the veterinary dentist says, I'm sorry, I can't do anything about this. You just got to make sure the tongue's moist and make sure that it doesn't dry out and there's no foreign bodies on it. There's just nothing I can do. But right as they're leaving, what does the dentist say? Well, I could have done a root canal on my tooth, and that would have prevented it from happening. So do you think the client's happy about that? No. So the client files a complaint with the board, said Happy Pet Animal Hospital did not talk about any other options. They didn't have, what's that phrase? Informed consent. They didn't know the options to the procedures. They believed they were just presented with extraction only. So we have two cases. One is filed against Dr. Brumbley and one is filed against Mr. Canal, because we all know now, after this talk, that the three main categories of licensees that can have a discipline or be the subject of a complaint are licensed veterinary technicians, hospitals, and veterinarians. So the investigator goes through the normal process and begins the interview process and talks with Dr. Brumbley. And Dr. Brumbley says, I told Mr. Canal to offer extraction or a root canal. I don't know why in the complaint I'm reading here that they said they just were offered extraction. I remember talking to Mr. Canal about this. And Mr. Canal says, yeah, I remember Dr. Brumbley talking to me about that, but I knew that they couldn't afford it. So it was the only real option. And that's all I talked to them about. Because again, in my opinion, it was the only real option for them. I knew they couldn't afford it. We looked at the dental radiographs and showed that there was a complicated crown fracture of that 304. It had a closed root apex and no evidence of abscessation. Why is that important? Any dental people in the dental here? Yeah, closed apex, no abscess means a root canal therapy could have been performed. All right, so the investigation committee meets and they determine that Dr. Brumbley acted within the standard of care, but they had concerns about Dr. Brumbley's communication. The committee dismissed the case against Dr. Brumbley, but issued what's called a letter of concern to Dr. Brumbley regarding that he ensured direct and effective communication with his clients. So this is a new term. Has anybody heard of a letter of concern? Because we talked about letter of reprimand, right? We talked about dismissal or discipline. We didn't talk about letter of concern. Is anybody familiar with a letter of concern? I've seen a lot of no's, yeah. So in this case, a letter of concern being issued, the case is still dismissed. So it is not it's not made public record. The letter of concern is not made public, nor is the letter of concern binding. The letter of reprimand is binding. We found these things, that this constitutes incompetence, and you must do these things. You must pay these fees and costs and attend the CE. If you don't, then you may be subject to further discipline. A dismissal, there's no further action. The letter of concern is therefore not binding. But Dr. Brumbley does receive a letter that says, hey, your case was dismissed, but we have these concerns. Our concern is that you talk directly with your clients, clear and effective communication with your clients. That may have prevented a problem in the future. But again, it's not binding, it's not a discipline, and it's not public record. It's just something for Dr. Brumbley to consider. And the committee determined that Mr. Canal failed to communicate Dr. Brumbley's recommendation and that he didn't offer alternatives to the tooth extraction. Dr. Canal inhibited the ability for the owner to make an informed decision. They did not have informed consent. So the letter of reprimand goes to Mr. Canal, and Mr. Canal agreed to pay the costs and the investigation costs, attorney's fees of $650, and attend 4 hours of continuing education on proper communication. You guys think that was fair? A lot of heads nodding, yes. Would you have done differently if you were on the committee? Seeing a lot of looks of like, yeah, probably not. How about the letter of concern? Does that make sense? I'm going to make sure I explained it correctly. Non-binding, suggestion, non-public record versus a discipline, binding, public record. Okay. Let's move on to case 5.
And I can ask
So
a question.
Of course, yeah.
So let's say Mr. Canal was not an LVT, Mr. Canal was an assistant. And you told an assistant, hi, can you, this patient's under anesthesia, I have to stay here. Can you communicate this with the owner? That then falls on the veterinarian's license, correct?
Correct.
Okay.
Even
so
if
then
it's the tech. Oh, go ahead.
Oh, sorry. So it would be the doctor's fault, even though they weren't involved in that communication.
Ultimately, all licensees involved in a case are part of the team and have shared responsibility. So if you've got a DVM and an LVT, they have shared responsibility. If you've got a DVM and a VA, because a veterinarian assistant is not licensed, the licensee is the responsible party, the DVM. There are some exceptions to this rule. There's always exceptions to every rule, of course. Veterinary assistants and people without a license technically can be the subjects of complaints, but it has to be unlicensed activity. So, for example, if a veterinary assistant extracted a tooth and they did it without anybody ordering them to or watching them, the veterinarian was not involved. Well, that VA is subject to discipline, but it's subject for unlicensed activity, practicing veterinary medicine without a license. But in your scenario, we've got an LVT and they tell the VA to talk to the owner. The VA doesn't give proper informed consent. Yes, that's going to fall on the licensee. And the board would have the option to either discipline that licensee, to dismiss outright, or to dismiss with a letter of concern, as they did in this case. And you can see in this case, the committee decided to dismiss the case against Dr. Bumbley because Mr. Canal didn't follow the order of Dr. Bumbley. So Mr. Canal kind of went rogue on Dr. Bumbley. If Dr. Bumbley had said, hey, I know they can't afford it, just tell them we need to extract the tooth, then they would both likely be equal co-responsibilities. It's a great question. Yeah. Where does the responsibility lie? Yeah, typically on the licensee. We are seeing more cases against veterinary technicians. We used to never see them. The first 10 years I was involved with the board, we never saw cases against LVTs. We're seeing more and more, and I don't think it's because LVTs are acting inappropriate or acting outside of their scope. I think it's that LVTs are becoming more of an integral part of the team. They have more abilities and therefore more responsibilities. But Allie, you had a question, or the two of you guys had a question.
I did. So if because I've had this before where doctors will hand things off to me as an LVT and say hey, can you call this owner and just let them know that they're on the right track, that kind of thing. There's just, I forgot what the kind of question was, but it was when the doctor puts that on me, then do they have to document later, the doctor themselves document hey, pass this, asked this LVT to call and communicate with the owner, and then my communication is in there? Because I've done that before where I will call an owner and just be hey, the culture results came back as negative, or the antibiotic that we put you on is working and it's susceptible. Does the doctor then have to document that they asked me to communicate for them, if that makes sense?
Yeah, who's responsible for the medical record? Is that a fair summary of the question? Yeah, it's a good question. Our regulations state that it ultimately is the veterinarian's responsibility for the content of the record, making sure it's complete, and then maintaining that medical record. So in code, it's in regs, it's the veterinarian's responsibility. In practice, it's a co-responsibility. You have a license, you have knowledge, skills, and ability, and you have responsibility. So the technician does have an input into the medical record. Ultimately, it's the doctor's say on that record because, again, in regs, it's ultimately the doctor's responsibility. So if the technician puts something in the record and the doctor says, actually, that's not correct, the doctor may make an addendum to correct the medical record. But in practice, as an LVT, I recommend obviously listening to the doctors, what they want you to communicate, taking notes, reading that back to them. So, hey, you want me to call them, tell them the culture is negative, and that means just keep an eye to make sure there's no more blood in the urine, right? Cool. And then document that in the record. That's the best practice. But in regs, as far as the state's concerned, it's ultimately the doctor's responsibility. Good question. Any other questions about medical records?
I don't have a question, but I'd probably like bounce off of what she says. Yeah, it's just basically putting everything in there, even as like a quick medical note, and just being like, doctor reviewed information, and I'm just letting the owner know that this is what they said. Because we do that when I was doing inpatient care. That's what basically we were doing every single time, is like notes, or if I got a verbal, I would always be like, so and so verbally stated, do this, this, and this, to cover our ass. Sorry, to cover whoever said it, to make sure that it was repeated back. I got the right information. And sometimes I'd be like, hey, write a doctor's note because I have 6 patients that I got to work with and I can't remember this. And then I'm like running around because something else happens. Or even my colleague would be able to look at that doctor's note and be like, hey, I can't do that right now, but can you look at it and do that following treatment? Or something needs to be said or done that this needs to be done right now while I can't do it. So I would always just cover your butt and just write a note, make sure this was being stated. And if you have any questions before you call, just ask the doctor, because that's what they're there for.
I agree. I think that's best practice. You know, as an investigator, I've find that the more information, the better. I'd rather see more information written in and then addendums to correct, like, oh, you know, I thought I recalled saying this. Actually, we didn't talk about that until the next day. You know, I'd rather see addendums in the record. Also, over my experience with the board, when we've had medical record violations or when we've had questions and we go back to the medical record, because one of the most common scenarios we see, complainant said A, doctor said B, where do we go to determine between the two? The medical record. And more often than not, when we go to the medical record, we don't have enough information to support one side or the other versus we go to the record and it's complete. So I think you can't be too thorough in your medical records. Okay, let's talk about Beatrice. So Beatrice was presented to my favorite mispronunciation of my name, Dr. Chumley, for ovarian hysterectomy and vaccination. Unfortunately, cardiovascular arrest was noted 10 minutes after induction anesthesia. It's the poor young kitty coming in for ovarian hysterectomy and arrest, and CPR was unsuccessful. Dr. Chumley recommends necropsy, and the owner consents. Who talks to people about necropsy when you have a sentinel event, an undesired outcome? Not many hands. Yeah, it's hard. It's really difficult to talk about necropsy. I believe that the more we do it, the easier it becomes. The discussion of necropsy, the more we perform necropsies, the more we learn. So the more we talk about it, the easier it gets to talk about. The more we do, the more we learn. I have a bulletin article on a case for necropsy, plugging for the bulletins. If you go to our website and you scroll down on the panels, there's one panel that says bulletin articles. All of the articles that we write have been archived. There's stuff on informed consent, on medical records, how to fire a client, and there's how to talk about necropsy and also how to perform a necropsy. So I'll get off that soapbox and move on. So while awaiting the results, though, the owner says, look, I want a refund. And Dr. Chumley says, well, hold on, let's see what the results are of the necropsy. I've done the gross necropsy, I've sent off some tissues. Let's see what the results are before I do anything. So the owner says, well, I'm filing a complaint with the board. So while they're waiting for the histopath results, they file a complaint with the board saying that they must have given the wrong anesthetic drug, and the hospital refused to refund the charges because the owner wanted their money back and the hospital refused that. Any thoughts on financial matters? Does anybody know, does the board evaluate disputes of finances? Correct. Dr. Schrader, no. The board does not take into account the business practices of a hospital during the investigation, other than when you're establishing informed consent, you do need to discuss cost. But other than that, no. The board is not involved with the business of veterinary medicine. That is handled by the DA's office, civil courts, and the Department of Consumer Affairs. So in this case, The investigator looks through the medical records, shows that the anesthetic drug doses were within published doses. Vital signs were recorded every 5 minutes. Didn't see any complications until, unfortunately, the cardiovascular arrest. The CPR procedure, drug doses, and monitoring were recorded in compliance. And then the necropsy reveals hypertrophic cardiomyopathy as the cause of death. Has anybody ever had this happen to them? Lose a kitty and then determine? I have. It was a rare hysterectomy and declaw back. This is probably dates me how old I am. Did the spay declaw. Cat did great. Cat woke up, ripped off the bandages, probably because of my poor pain control at the time. I learned a lot since then. Then I needed to anesthetize the cat because it became fractious, and unfortunately it died when we were anesthetizing just to remove the bandages. So in this case, necropsy did support that it wasn't something that Dr. Chumley did, that it was just, unfortunately, a cult hypertrophic cardiomyopathy resulting in death. So in this case, the committee determined that the anesthesia, CPR, everything looked to be in compliance with regulations. And then the committee did not consider the disagreement about the refund in their deliberation, because again, the board does not have the authority to evaluate the business of veterinary medicine. So the case was dismissed and no further action was taken. Any questions on that one? Or any personal experience? Nope.
We didn't know that the cat, well, we did the necropsy. I mean, there's not really much that you could have done unless the cat was showing signs that it was having problems with its heart before going into surgery. So even the blood work wouldn't reveal problems with the heart if it was a 1-year-old cat.
Correct. I was just looking through my notes. I don't think I wrote on there that there was no heart murmur on the pre-anesthetic exam. Let's just say, yes, there was no indication of heart disease prior to the anesthesia. Yeah.
Okay.
Right. The only thing you could have done was an echo. And if you require an echo on a 1-year-old animal every time, like that's probably not super realistic.
Yeah, it'd be cost prohibitive, and it's also wouldn't be considered the standard of care. So, for example, if the board had felt the standard of care was do an echo on every cat prior to anesthesia, well, then it would be a violation, but it's not considered the standard of care because that would be cost prohibitive. And we all know we probably wouldn't do a lot of spays or neuters if that was the standard of care. And it's not the standard of care in human medicine either. But let's say in this case, the necropsy wasn't performed, because those are a majority of my cases, and that's why I wrote the bulletin article on the case for necropsy. What do you guys think in this case? If you were on the board and we didn't have the definitive necropsy showing hypertrophic cardiomyopathy was the cause of death, what do you think you would rule?
Well, looking at it objectively, I'd been like, well, did we do blood work? Did we see a heart murmur? Did we see any problems beforehand? Is there anything stating that the cat was having any issues before? And if everything was done correctly, I would probably chop it up to something was wrong with the cat before and we just didn't catch it, or it's just things happen. And we're covering all our bases by making sure we're keeping up with the monitoring. We are giving the correct dosages. We're touching base with our doctors and touching base with our nurses and making sure that the patient is being given the proper care. Because like you said, if we're going to do an echo on a 1-year-old cat that is a Persian, we're also thinking, well, you should be a healthy cat unless there's something indicating that otherwise. And if it's not going to be safe, you should be going with an anesthesiologist that's going to cover the arrays of problems that can happen, and you should have a surgeon be cutting it, because things can happen and we have to make sure that we have a plan B or another plan set if something happens.
Yes, that's very, very good. I agree. It's the outcome. It's not that the outcome isn't important. Losing Precious was terrible. Losing Beatrice is terrible. So the outcome is important, but the outcome is not determinative whether discipline is decided or not. It's the process. With the information provided, did the doctors and technicians follow the standard of care? If they did, despite the outcome, there would be no cause for discipline. If they depart from the standard of care, that's the violation. So it's not that the outcome isn't important. It is. Loss of a pet is tragic, but it is not determinative of the outcome. You want to knock through another one? I see some heads nod. Okay. All right, we got Anna. Anna's a 5-year-old female spayed poodle, presented to Dr. Chumpley's emergency clinic for acute onset of not eating and throwing up. Dr. Chumpley diagnosed acute kidney failure based on azotemia. I mean, the BUN was through the roof, the creatinine's double digits, and isostenuria on UA. Dr. Chumpley recommends diuresis, but stress, there's a poor prognosis here, and euthanasia is an option. So the complainant says, I don't believe you, Dr. Chumpley. You don't know what you're talking about. I'm going back to my regular veterinarian. It's 4:00 in the morning anyway. My vet opens at 8. I'm gonna go see my regular vet in the morning. So what does Dr. Chumpley do? Dr. Chumpley does what I would have done and says, fine, great. I've got 5 other emergencies. I'll make sure he's comfortable while she's here, and then you go to your regular vet in the morning. So they take Anna to the regular vet a few hours later when it opens. And then Dr. Chumpley says, hey, before you leave, I want you to sign this against medical advice. So does anybody use against medical advice forms in their practice? Yeah, good. Here's a question. And I remember now what my prior question about medical records was. Does an against medical advice or any notation in the medical record for that matter of a recommendation or somebody declining a recommendation, does it need to be in writing? Lots of nodding yes. How about consent for euthanasia? Does that need to be in writing? How about consent for anesthesia? How about consent for a vaccine? Yeah, so still some noddings, but less. How about consents for toenail trim? So the answer to all of them is it doesn't have to be in writing. So to obtain informed consent, it does not need to be in writing. We can have verbal consent. So we can obtain verbal consent for any procedure, and that is adequate, as well as the declining of a procedure. But is that best practice? No, especially for something like euthanasia or someone declining urgent medical care. It is best practice to get in writing because again, if you have, let's say you have I recommended, they go to the emergency hospital, they didn't go. I talked to them, this was against medical advice, they took the kitty cat out, then something happens, they file a complaint with the board. What do you think the complainant might tell us? Well, they never talked to me about an emergency clinic. And then we go back to the medical record. If there's a notation in the medical record that was made on that day that says the doctor wrote, well, I told them to go to the emergency clinic, that is evidence that that the doctor had done their due diligence. Also, if we look in that medical record and we see there's a against medical advice form that says we recommend you go to the ER, and they didn't go. And look, it's even signed by the complainant. The evidence starts to stack up in support of the veterinarian side of the story versus the complainant side of the story. But according to regs, we can obtain consent verbally. We does not need to be in writing. However, I always recommend, especially if it's contentious or especially if it's a high risk procedure or if it's irreversible, such as euthanasia, it's a good idea to get it in writing. But you can have an AMA, and I have this in ER all the time, where I would present somebody an AMA form and they wouldn't sign it. They just walk out the door. Does that mean that I didn't tell them that they're leaving against AMA? No. And did I go back into the computer and type in told client presented with AMA form, they walked out without signing? Yes, of course I did. And that's best practice. Okay, but in this case, they did sign the AMA form. Dr. Chumpley got him to sign it because Dr. Chumpley's a convincing dude. All right. Oh, I hit the slide too fast. Who, raise a hand, who knew that later on Anna was diagnosed with Addison's? Oh, so yeah, Anna, middle-aged, poodle, azotemia, acute onset. Addison's got to be one of your rule outs, or hypoadrenocorticism. So the complainant calls Dr. Chumpley's hospital and says, hey, Dr. Chumpley misdiagnosed my dog. I'm very angry. And Dr. Chumpley tells the receptionist, tell them I talked to them about Addison's, but I really thought kidney failure was more likely. So the complainant tells the receptionist, Dr. Chumpley's stupid, idiot, starts getting belligerent. Receptionist hangs up on them, which is totally their right. We do not need to suffer abuse of our clients. When clients become abusive, you may terminate that veterinary client-patient relationship. And then Dr. Chumpley says, the receptionist goes to Dr. Chumpley and says, hey, this happened. And Dr. Chumpley says, I'm not calling them. And I'm gonna fire him. I'm gonna send a termination letter terminating the VCPR, or veterinary client-patient relationship. So investigation, we get the medical records, the response, and the investigator sees that a differential diagnosis of Addison's and renal failure were in the records from Dr. Chumpley. And there was a diagnostic plan, including resting cortisol. And then looking at the primary veterinarian's records as a secondary facility, they did see hypercortisonism was appropriately diagnosed and it did well with treatment. What do you guys think? You were on the board. What would you do? Allie's shaking her head no. Rebecca's going, I don't know. Dr. Quilling's thinking this has nothing to do with dermatology.
I would probably side with the veterinarian as long as everything is noted and it was stated, and then the owner was aware that they basically said, I don't want to continue further treatment with Dr. Chumpley. Is that what we have?
Chumpley.
Okay, I was like, that's who we have. Based off the information that we have, and we did tell them, hey, these are your options, but you so chose to go with your PDVM. So here's your AMA form. If you don't want to sign it, fine, but I did give you the information, and you do with it what you will, basically. So in this case, I'd probably side with the veterinarian. I was like, you gave them all the information, you gave them a treatment plan, you gave them everything, and they chose not to follow through. And I was like, they have the right to have that opinion or that decision, but it shouldn't be falling upon the other doctor where they did give you all that information.
I think ultimately,
you look at where the evidence supports. What side of the story does the evidence most support? And is there evidence of potential miscommunication? Dr. Quilling?
Oh, I was going to say just that, like, okay, was the first person wrong in that it wasn't truly kidney failure? Yeah, sure. Like, hopefully they can learn from that. But an Addisonian crisis doesn't have a great prognosis either. Like, it's not, the prognosis wasn't different. It's just that the diagnosis wasn't totally correct, but the prognosis remained similar. So hopefully they learn, and myself included. Like, I absolutely would have missed that if I was on ER, which is why I just do skin. But like that seems reasonable. You knew the prognosis was poor and you communicated that to the client.
And it could have gone the other way. Dr. Chumpley could have been right. It could have been his presumption. Renal failure could have been the diagnosis. Just in this case, I chose for it to be Addison's, but it could have been the other way around. What's important is Dr. Chumpley contained within the standard of care, or did not depart from the standard of care in the workup, making the appropriate recommendations. Mm-hmm. Yeah.
Question. Did he have messed up lights? Because that is what's going to tell us. I just thought of kidney disease too when I saw that, and I was like, okay, well, what stage of kidney disease do you have an AKI from? Did you eat something? Did you have that problem? And then, the hyperkalemia. Yep.
Why didn't I say that out loud? I wonder. I was trying to lead you guys over.
I saw kidney disease, but then I when you said that, I was like, oh, okay.
I didn't want to give it away.
I didn't read. I was listening.
I appreciate that. Thank you. All right. So in this case, the committee determines there's no departure from the standard of care. Dr. Chumpley was followed the appropriate diagnostic and recommendations, but they thought about why this complaint occurred. And the committee was thinking, there's some evidence of miscommunication here. I can see how Dr. Chumpley believes he talked about these things, but maybe the client doesn't remember it because there's evidence of contentious conversations from the onset. Remember when Dr. Chumpley said, I think this is kidney failure? And they said, you're an idiot. I don't think you know what you're talking about. I'm going to my regular vet. So the committee thought there is possible miscommunication here, which also could be why there's disparity in the recollection, but also some areas for improvement. So can you think, if you're on the board outside, there's no breach of standard of care, so I don't think discipline is warranted unless you do. What other method could you, as a board member, what other thing in your toolbox can you use to possibly get at the root of this so it doesn't happen again?
Letter of concern.
Absolutely. Yeah. So the committee issues a letter of concern to Dr. Chumpley and says you really should consider using clear, direct communication when clients have concern about your diagnostics and your care, and also when terminating the veterinary client-patient relationship. As you would probably guess, terminating a VCPR is uncomfortable, right? It's like a breakup. It's saying, I don't want to do this anymore. We're breaking up. What is best practice for terminating the VCPR? I have a bulletin article in it just to plug for those, but I see Allie's group has a hand up, so you can ask your question if you give me a best practice for terminating VCPR. Either one of you guys. Put you on the spot.
I guess just saying like this relationship, I don't know, both of us work in an ER, so like that was where my question was or used to. So that's where my question was kind of coming from, of like, if a doctor doesn't work well with a client and needs to terminate that practice, is it okay for like the entire practice to say like we're not seeing this patient anymore or like this client anymore, or is it more of like on a doctor's discretion? That was like my question, but I don't know like how, like, I don't know. Yeah.
Okay, I'll answer it, and then I'm going to give you a multiple choice on best practice afterwards.
Okay.
So in the 2003 AVMA Ethics Code, veterinarians have the right to refuse service. There are some exceptions under emergency conditions, and there's exceptions to that. I'd encourage you guys to look through that legislation, or if you have questions about it, I can go over it with you. But the sum of it is the veterinarian can terminate the veterinary client-patient relationship with themselves as a veterinarian or with the hospital as a whole. To do that, they must use courtesy and tact. That's in the AVMA Ethics Code. So best practice to terminate the VCPR, and you want to use courtesy and tact, and you are the professional, you want to be professional. What would you say of this multiple choice? What's the best way? An email after the client's left that says, we're terminating the VCPR, here are your records. An email after the client's left that just says, we're terminating the VCPR. A certified mail to the client that says, we're terminating the VCPR. Talking to the client when they're there, saying this relationship isn't working, I'm going to terminate our relationship and recommend you go elsewhere, and providing copies of the record, or A, B, C, D, E, all the above.
Personally, I think talking in person is like best practice, but then like you kind of have to assess the situation, because I'll speak as a former part of Dr. Schrader's team, that there was communication that could only happen via email. So she had to terminate that via email, because you couldn't get through them in person talking to them, because they would just talk in circles, like talk you in circles. So like talking, I believe, is the best practice, but then like you kind of just have to do it on a case-by-case basis of how can you best like tell the person this is done, we're done, kind of thing like that.
No, I agree. Having that one-on-one conversation, or at least attempting that, is important. We're human beings. We should give each other the dignity and respect of talking one-on-one. And then follow that up with written documentation, either send out a letter or an email. I believe nothing cements the termination of VCPR of handing the client the record at the time of saying, I think it's best you go somewhere else. I am not going to provide services, or this hospital is not going to provide services with you anymore, or you're no longer welcome at this hospital. Here's a copy of your record. I wish you and Beatrice the best. But you're right. You have to tailor it to each individual circumstance, because sometimes there's people don't want to talk to you at all or at that time. I find that best practice is for the person who's terminating the relationship, albeit the hospital administrator, if it's the whole hospital, or the doctor, oftentimes it's the doctor, them to talk directly to the client or attempt to talk directly to the client. Don't relay it through somebody else. Talk directly to them as a human being, hand them the record, and then follow up with something in the mail. Or if they won't listen and the conversation becomes too contentious, end the conversation, follow up with a letter or email.
As I say, I usually I've only had to fire like 2 clients, but when I've gotten close, I always give them the opportunity and say, I feel like I'm not meeting your needs. We're not getting where you feel like you want Fluffy to be. You've expressed concern, you've expressed frustration. And so where can I send your records? How can I help you get the help that you want? Because I don't feel like I'm meeting that, like kind of put it on myself, even though I'm like, is it me? I don't know. But anyways, I kind of give them a chance to fire themselves. And usually they take that opportunity. And then if they come back around and they want to be nice and they want to work together again, then like, so be it. But then the couple of times where I've like truly had to fire them, we've had those conversations, they become abusive or whatever. And then they end up, when I was at UC Davis, they got a letter and a call from the director of the hospital. And then like most recently, they had a conversation with our admin team. But like, I give them an opportunity to fire themselves first.
Well, that's a good point. Dr. Quillen, have you found that conversation when you opened that door has oftentimes resulted in that client becoming a better client or having a good relationship with them moving forward?
Not typically. Usually then they just go, I do want to go somewhere else. And I go, great, I really hope there's somebody who can meet your needs. It's usually like not, and I had this conversation with someone who's in residency right now who was saying that the social worker at their hospital was like, so a lot of these people actually have borderline personality disorders, and when they go to the next one, they're going to do the exact same thing. And I was like, that's exactly what I've seen. So great. I'm glad it's confirmed by a professional. But it's usually.
But I like how you said it puts it on them. It makes it their decision. And
Right.
And if you make the decision, then you have ownership of it. That's a very good point.
Right. And I usually just repeat back to them, you just told me that you are not, Sadie, stop. You are not happy with how things are going. So, sorry, she's going to she thinks it's wrong. I'm going to pause.
It's
Mute myself.
time for WALK.
Apparently.
It's better than my dog farting underneath the table. So I'm right there with you.
You have friends.
Okay.
You did that to your
I know. It's consistent. Yeah. It's just window open at all times. I want to get into this next case because we're starting to run out of time, and I want to go over this case because it's fairly unique and it is a pattern that we see. So in this case, it's not one specific patient. These are numerous dogs and cats. So Miss Nuevo, she starts a new job as a licensed veterinary technician at Loving Hands Veterinary Care. During that first week, Miss Nuevo is informed about the hospital policies of Loving Hands Veterinary Hospital. You can probably realize I'm starting to run out of names for hospitals. That isn't an actual name of a hospital in Nevada. So Loving Hands. All right. So the hospital policy there was the technicians remove any tooth that the veterinarian determines needs to be extracted. So Ms. Nuevo's new employee, she does what she's told. She removes several teeth under the direction of several different veterinarians at the hospital, but always kind of felt uncomfortable with this policy because it didn't fit with Ms. Nuevo's understanding of what she was taught in technician school. So she does the right thing. She brings it up to her manager, and the manager tells her, follow policy. So if you were Ms. Nuevo, what would you do? Any other avenue you think you can pursue? Alicia.
I actually had this problem a lot when I was moving back to California because in Nevada, we weren't allowed to extract, but in California, we are. So a lot of the times I would, even before I would accept a position, I'd tell them, like, I don't know. I was very clear. It's like, I don't know how to do extractions. I don't know how to do what you're asking of me because that is not what I was taught. And I'd make it very clear, it's like, I'm not comfortable. I'm willing to learn, but it still has to be under the direct supervision of a doctor right there with me, or somebody that knows what they're doing before I will even be comfortable doing it. Because
Yeah, that's a good way when you approach the manager saying, I'm not comfortable doing it. Even though I know it's allowed in California, I'm not comfortable doing it because I'm from Nevada. And in Nevada, I can only extract teeth with gross mobility. Yeah, that's a good point. So let's say that in this case, Ms. Nuevo brought those concerns to the management. The management says, just do your job. And so Ms. Nuevo decides to call the board and says, hey, is this hospital policy in compliance with regulations? You can always call the board. You can call me directly. If I don't know the answer to the question, I'll refer you to our licensing specialist who does. But in this case, Ms. Nuevo called our board, spoke with our licensing specialist, and was told that's not in compliance. That if that hospital policy, if true, because again, at this time, we don't know if it's true or not. We just have Ms. Nuevo's word. That would be a violation. So in this case, the board filed the case against Loving Hands Veterinary Hospital. And the contention was, you're allowing licensed veterinary technicians to extract teeth without gross mobility, which is not allowed in Nevada, but is in California. During the hospital inspection, the board inspector obtained medical records that showed several patients that had dentistries and extractions recently. The board investigator reviewed those inspections and then interviewed technicians and doctors involved in the case. Most of the technicians, no surprise, said, yeah, that's the policy. But when the investigator talked to the veterinarian in charge, the veterinarian in charge said, no, our policy.
hospital policy, what they have actually
Yep.
written.
Exactly. A gold star. Not quite as much for pneumocologram, but darn close. Yes. And the veterinarian in charge said, that's the policy, but I don't have a written policy. No, everybody knows it. Everyone knows it. So in this case, the committee met and they had these two different stories, and they're trying to decide between the two. And in this case, the committee felt the evidence was more supportive of Ms. Nuevo's recollection and the technician's recollection that, yes, that the hospital policy was to have the technicians extract teeth, even if the teeth did not show gross mobility, and that was a violation resulting in discipline. So the hospital was disciplined in this case. And a letter of reprimand was sent to the veterinarian in charge, because the veterinarian in charge must answer for the hospital because the hospital can't speak. So the veterinarian in charge gets the letter of reprimand. So let's talk about what types of discipline, because in this case, we've determined you've got technicians extracting teeth without gross mobility. You've got doctors telling them to do it. We don't want this to happen again because this is a violation of the standard of care. Can you think of ways to tailor the discipline? And I'm going to take the easy ones out of the way. You're going to get fees and costs. You're going to do some continuing education, let's say 4 hours of CE on dentistry. What else would you do? Maybe in addition to that, online CE, what else you would do? And then maybe some other things that you could consider this hospital to prevent this from happening again.
I would say having like random inspections. As a technician, I've been in this situation where I was asked to extract teeth that was not okay, obviously. And I said no, but to randomly inspect them and see if technicians are still extracting teeth or whatever it may be.
Excellent. Yeah. Submit for random inspections, maybe on the days that we know they perform dentistries too.
Maybe have them write the policy out that they're only supposed to do gross mobility.
And provide that to us.
Mhm.
Yep. You can even have the staff members sign off on it. You can require that. All good stuff. Yes, you guys predicted a lot. Of course, we had fees and costs, sure. Written policy that they are in compliance, that their dental extraction policy is in compliance. Unannounced inspections. And then the committee also thought maybe the doctors are doing this because the doctors don't know how to extract the teeth. Maybe this is one of those hospitals that had always had the technicians doing the extractions, and you get these young new doctors that come in, they don't know how to do extractions. I came out of veterinary school without ever doing a dental, never extracted a tooth, never did a dental cleaning. So I came out of practice and I've got to extract these teeth. I've never done this. So I attended wet labs. I shadowed veterinary dentists so I could learn. And in this case, the board compelled the veterinarian in charge of the hospital to take wet lab components for a teeth extraction. Because if you have the boss do it, what do you think is going to follow? Boss is going to make everybody else do it. So can you see that these disciplines are designed not necessarily as punitive measures? They're designed that if a mistake was made through incompetence or negligence, the board's goal is to reduce the likelihood of that happening again. I always say the mission of the board. That's a good question for you guys. The mission of the board, let's give it a multiple choice. What's the mission of the board? To be an unbiased arbitrator between disputes of clients and veterinarians, to be advocates for the veterinary profession, or to protect the public and their pets. What do you think the mission of the board from the governor is?
All of the above.
Oh, it'd be great. That would be great. It's only one. I agree with the sentiment, though.
Would it be B, advocate for veterinary professionals?
That would be the Veterinary Medical Association. So the NVMA is your veterinary advocate.
It's for the client and the pet, and making sure that things are going well, and making sure that we're proceeding with the proper cares that we are having in guidelines for all of us in the profession.
It's the protection of the public and their pets. The mission of the board is to protect the public and their pets. To advocate for the profession, that is the NVMA, the Veterinary Medical Association. Unbiased arbitrator, that's the civil courts. Our job, as dictated by the governor's office, is to protect Nevadans and their pets. I always say the best way of doing that is to work with good veterinarians that make mistakes, because that's the majority of our profession, good people who make mistakes. All right, so if you made it this far, congratulations. Like I said during the presentation, of course, you weren't able to ask questions during the virtual presentation, but this is my contact information, so feel free to reach out to me anytime with questions or comments regarding the presentation or about the investigation process in general. After this presentation, you'll receive an email from me with a link to a short quiz, which you'll be required to complete and submit to receive your 2 hours of continuing education. Thanks again for joining me. Take care.